conference. Good morning, all delegates in Durgapur. First, my very, very sincere thanks to Dr. Vishwas for this very, very kind invitation and also his understanding that I couldn't be there in person due to my dad's health issues. And strangely, he had a fall yesterday and a fracture, and that's what I'm going to talk to you about today, osteoporosis for the practicing physician. This is a topic that is very close to my heart because the Indian Society for Bone and Mineral Research is the one society that I have been attached with for many, many years and was the most recent president of the society, the past president. I want to start with the definition of osteoporosis. The old definition used to be that it was about low bone mass, microarchitectural deterioration, and therefore a tendency for fragility fractures. But now the new definition is that it's a systemic skeletal disease characterized by not just low bone mass and microarchitectural deterioration, but is really all about also bone quality. So, bone mass and bone quality make up bone strength. That is the new definition, that it is actually a decrease in bone strength. And bone quality is made up of a lot of different features, from mineralization to matrix composition to micro cracks and micro fractures. So, and why this is important is there may be some people who have, for the same bone mass, if you do a bone density, they may have the same bone mass, but one may fracture and the other may not fracture easily, and that may be because of bone quality. And bone quality changes with age, with medical conditions, so we'll talk about that as well. Is osteoporosis on the rise? The answer is a definite yes, especially in Asian countries. And India is a very, very vulnerable area for osteoporosis. And we also seem to have about fractures about 10 years or so earlier than our Western counterparts, just like most other chronic diseases. And osteoporosis in men is also quite common in our part of the world, and we should be aware of that. While definitely osteoporotic fractures and osteoporosis is more in women because of changes after the menopause and other reasons. But it's also a very important thing to keep in mind in men. So what are the factors that affect both bone mass and bone quality? I just want to show you what happens to the bone in a person's life. So we reach our peak bone mass somewhere what we thought was around 30, but in reality it is closer to our late teens or early 20s. So protecting the bone health or building the bone health of our adolescent girls and boys is very, very important. And then we maintain a plateau for a while, and then there is a small age-related gradual decline. Then there is a big decline in women around menopause, and then there is age-related decline in both men and women. And once we reach the fracture threshold, then we start fracturing easily. So you can see that if someone starts with a low peak bone mass, this is going to be a challenge for them because they will fracture easily. Factors influencing peak bone mass are heredity and genetics. As I mentioned, gender, women have lower peak bone mass than men, and nutrition during our pre-adolescent and adolescent years, especially calcium, vitamin D, protein. And then if there are illnesses, especially hypogonadism or conditions like excess use of steroids or conditions like Cushing's and many other medical conditions. And puberty-related medical problems and mechanical factors like physical activity, body weight, smoking, alcohol, and other factors. And just to quickly show you what happens as an example in women, if you take pubertal girls, formation is more than resorption, so the net balance is good. When you take, premenopausal women, resorption is already taken, over a little bit, and so the net balance is already down a little bit. But in postmenopausal women, clearly the resorption is more, so the net balance is much lower. When I say premenopausal women here, you could think of it as more like a perimenopausal women are in the years before the menopause. And we know that as people get older, age is a really important risk factor for fractures and osteoporosis. So for the same bone density, if the person is in their 70s or 80s or 90s, their risk of fracturing is much more. And fracture risk increases in people with diabetes. In our country, with over 100 million people with diabetes, there is a very high risk of osteoporosis and fractures, not only due to bone quality and bone mass being lower, also because the advanced glycation end products and other changes that happen during with diabetes affects the bone quality. Plus, retinopathy and neuropathy and other issues, sarcopenia, increases the risk for fractures. Another risk factor is obesity. We always thought that obesity was protective of osteoporosis because there was insulin resistance and insulin was anabolic and there was probably a little bit more androgens. So we thought obesity was protective. But now we have understood better that the cells go more into the pre-adipocyte and the adipocyte and less of it is into the osteoblast. So actually, obesity is a risk factor. So if you take the pathogenesis of osteoporotic fractures, so many things, postmenopausal bone loss, age-related bone loss, other risk factors we have talked about, starting with low peak bone mass, poor bone quality, and non-skeletal factors like propensity for falling. Someone has dizziness, hypoglycemic episodes, they are more likely to fracture. So this all contributes finally to a fall and a fracture. So this fall is a very important thing because if you really think about it, if one doesn't fall, chances of fracturing are less unless they lift something heavy and there are vertebral fractures happening. So if you just look at fracture facts, a lot of fractures happen per year. The IOF says 2 million bones break in a year, 2 million too many. And 1 in 2 patients with osteoporosis gets a follow-up test or treatment for osteoporosis, which means 8 out of 10 patients don't. And fractures will have serious consequences. And hip fracture, 10 to 20% additional mortality per year, and 20% of the fracture patients require long-term nursing home care. And all you can look at it is they need assistance even for their daily activities. And only 40% or so fully regain their pre-fracture level of independence. When you take osteoporosis in India, public and physician awareness about the disease and its impact continue to be low in our country. The long-held belief that osteoporosis is a disease of the West and does not exist in India. The notion that osteoporosis is an inevitable consequence of aging, which can neither be treated nor prevented. Preoccupation of the health planners with other conditions, infectious disease, other non-communicable diseases, limited availability of diagnostic facilities across the country, and paucity of epidemiologic data. I wouldn't really say this because I think plenty of research has been done in our country on normative data, on epidemiologic data. Still more can be done. And we know that patients with a prior fracture are at greater risk for future fragility fractures. As you see here, if someone has had a hip fracture, they are at greater risk for a vertebral fracture and another hip fracture. As I mentioned already, survival rates after fractures are lower. When you define osteoporosis, we've been using the WHO organization's criteria for diagnosis using bone density measurements. Normal is up to -1. Okay? Osteopenia is between -1 and -2.5. Osteoporosis is anything more than -2.5. And severe or established is, of course, anyone who already has a fracture, not someone who fell from the fifth floor and broke something, but we are talking about fragility fractures, so severe or established. How do we evaluate someone with osteoporosis? Of course, we have to take a very good history and physical, largely to look into family history and their other risk factors and what medications they may be taking that's contributing to bone loss, other medical conditions that they have, in smoking and alcohol intake, their nutritional practices, and any recent weight loss. These are very, very important. For example, with diabetes, use of thiazolidine has been shown to increase the risk for fractures, more so in women, but also in men. So, taking that history is very, very important. Laboratory investigation, more to look at things like CBC, rule out things like multiple myeloma, might give a clue to other conditions. A calcium level and an albumin level, largely to find out if the patient could be having hyperparathyroidism. So very simple, minimal workup. The rest will be dictated by the clinical, presentation and the clinical picture, rather than a battery of tests for everyone. And imaging is very, very important. I'll talk to you about that. And this thing called the fracture risk assessment tool. For our country, something this is free actually. There is now a Frax Plus, which is actually a small subscription is needed, but Frax is free. See, with osteoporosis, we don't have any other way of knowing. Nobody's going to find bones all over the house as you see in this cartoon. So bone loss is not like that. We really have to look for it. So rationale for testing is, how do we even know the extent of bone loss? How can we predict fracture risks? How can we know if it is age-related or secondary? And how can we monitor response to therapy? This is why we need to test the patient. And how do we make the diagnosis? It could be an X-ray, it could be its bone density or fracts. I would feel ultrasound primarily to say don't do it because it's not something that provides any useful information and could be misleading. And there are other risk prediction models that have been developed, like OSTA and COSTA and so many things like that. So when it comes to DEXA, which is dual energy X-ray absorption, we usually do the spine L1 to L4 and leave all four of them and look at the total. And we also look at this hip, the neck and the intertrochanteric area and the bond spine and the total hip. But we look at the neck and the intertrochanteric space, and whichever is lower, we take that into account. Both of these are very, very important. You also need to make sure that they're not discordant, meaning the spine looks good, but the hip looks bad. That's just not possible because usually bone loss starts in the spine. So we have to get an X-ray of the spine that's something that I'll talk about in a minute. But we talk about -1 to -2.5 being osteopenia, and here as physicians, I want to impress upon all of you that more people fracture in the osteopenic range than in the osteoporotic range. So let's not ignore osteopenia, but evaluate it further and consider treatment if someone has got a bone density, let's say, -2 to even -2.5. An X-ray of the spine is super important in everyone who has osteoporosis because vertebral fractures are something most often people don't see. If it's a hip fracture or a leg fracture or an arm fracture, we will know about it. Spine, we won't know. They might have some chronic back pain or just loss of height or a curvature of the spine. So unless we X-ray, we won't know. And very, very important this point, the greater the number of prevalent fractures, the greater the risk of future fractures. So if you find one fracture or two fractures, the risk of future fractures are that much higher. So what is this FAST? It's a simple online tool. This shows, American flag, but we have data for India, which is computed from Singapore Indian data. We also have Indian data now. So we can, feed in the information of the patient and their risk factors, and it will come up with major osteoporotic fracture risks and hip fracture risks. And based upon what that shows, we know that there is a risk for fractures in this patient. It doesn't give it won't quantify like a DEXA can do. And we also cannot use for prognosis or monitoring the patient, because it just gives you, this is the risk because the risk factors are usually, stable, and the other demographic features, the patient's data are not stable, except the age may go up. So we really are not going to get information from facts on monitoring the patient. You can also add BMD and the clinical risk factors, and the facts can predict fractures better than either alone, obviously. So it will give us a 10-year fracture probability of the major osteoporotic fractures. And the clinical risk factors are previous fracture, parent with a hip fracture, current smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis with no BMD, excess alcohol intake more than 3 units per day. Doesn't give, as you can see, there's no diabetes in this. So if your patient has diabetes, you can use rheumatoid arthritis as a surrogate and calculate the risk score. What about bone turnover markers? Like the markers of bone resorption are N-kilopeptide, C-kilopeptide, deoxyribonucleic links. Markers of bone formation are bone-specific alkaline phosphatase, osteocalcin, and T1NP. These are things that we don't use to make the diagnosis. These can be used for checking on compliance or response to therapy. So it's really a more nuanced use for follow-up of some patients, not everyone. I mentioned laboratory investigation. So a CBC, a calcium, and albumin. You can also look at a phosphorus, which we can predict for hyperpara, secondary hyperpara, malabsorption. I would also get renal function, because renal osteopathy is very, very common. And if the patient is also anemic, and if you have a suspicion, do get a serum protein electrophoresis to rule out a myeloma. If they're all thyroxine, definitely I would get a TSH, because suppressed TSH, especially in postmenopausal women, increases risk of bone loss. Vitamin D, I think, is very useful because there's a large osteomalacia component in the osteoporosis. Because on a DEXA, when you see low bone mass, you really cannot differentiate between vitamin D deficiency and osteoporosis. So vitamin D levels are helpful. And the other test, like testosterone, if a man has osteoporosis, especially early but at a younger age than expected, definitely rule out hypogonadism. So this is the last test that we need to do. And as I mentioned, there's a strong osteomalacic component. Osteomalacia is soft bone due to vitamin D deficiency. Osteoporosis is thin bone due to age and hormonal deficiencies and things of that nature. So if we want to optimize vitamin D, though it says here acceptable is 20 to 30, we usually try to keep it above 30, but definitely don't try to aim above 50 in our patients. This is very, very important. Who should be treated? We make sure that for all postmenopausal women and men aged 50 and older, if they have a T-score that is more than minus 2.5, when they say here minus 2.5 and I said more than minus 2.5, minus 3 and minus 3.5 and minus 4 is what I mean when I say 4. And if they have hip or vertebral, clinical or morphometric fractures, that's osteoporosis. Osteopenia is minus 1 to minus 2.5, and fracture failure probability of hip fractures, greater or equal to 3%, or major osteoporotic fractures greater than 20%. These people should be definitely treated. Fortunately, the treatment of osteoporosis is actually easier than all that I've talked about so far, because right now, even though there is a big laundry list of medicines and all that, we have narrowed it down to just about 4 drugs, and I'll tell you how I choose which medication for whom. But before that, I want to